Good morning, everyone. We will call this meeting to order. I want to welcome everyone to this last meeting of the decade. Next time we meet will be 2020. Yes, it makes me nervous. Right? So next time we meet, it will be the year 2020. Why don't we get started with approval of the minutes? I'm looking at Dr. Foreman.
Good morning. So I had only one, I think, substantive comment. On page 10, line 18 and 19, better translation there is meaning, comma, there may not actually be pathogen that is viable anymore for transmission. Opposed to what's written there. This was about the use of non-culture tests. And then on page 11, line 5, I think the word should be about, not the word by. And that's the only substantive one.
Okay, terrific. Anybody else? All right, motion to accept the minutes as amended? Sorry, as amended?
So moved.
And seconded. All in favor?
Aye.
Any opposed? Okay, terrific. So, today we are going to discuss amendments to Articles 43, 47, 48, and 49, all related to children, school-based programs, summer camps, and schools. And so we will take the votes for each of these amendments separately, but we will do the presentation all together. So I am going to turn it over to Deputy Commissioner Corinne Schiff, Assistant Commissioner Hawkins, and then I'll turn it over to them. Thank you.
Good morning. Corinne Schiff, Deputy Commissioner for Environmental Health, and I'm here with Assistant Commissioner Simone Hawkins. We're here first to present our proposed amendments to Health Code Articles 43, 47, and 49. And just first some reminders. Article 43 regulates child care serving children ages 3 to 5 in programs associated with the school. Article 47 is child care serving children birth to age 5 in center-based or shelter-based drop-off care. And Article 49 addresses schools, public schools, and also private and charter schools. To remind the board, our proposals overall are to update Articles 43, 47, and 49 in light of the new state immunization law, to update Articles 43 and 47 in light of new state and local laws addressing furniture, single-use polystyrene, and lead-based paint. Can't get rid of that frog. But clarify Article 43 and 47 regarding communicable disease exclusion requirements, expand Article 43's health and safety provisions and clarify enforcement protocols, revise Article 47's group size requirement, and set standards for Article 49 medical rooms. That's what we proposed to the board when we last met. We published the proposals in the city record, and the comment period closed on November 15th. We had a public hearing on that date. 3 people testified. We also received 13 written comments. Several of the comments asked for additional guidance, and the department will be providing detailed guidance both in writing and on site during inspections. And then there were some comments that requested changes to the underlying local laws. That's beyond the board's authority, so we are not addressing those. First, the comments on immunizations, and those go to Articles 43, 47, and 49. There were objections to staff dosage requirements. Our proposal to you follows the CDC's Advisory Committee on Immunization Practices recommendations for high-risk settings, which child care programs caring for young children we think are high-risk settings, and so we did not make changes. Other comments said that it was unclear how to submit requests for medical exemptions, and we're proposing to use the typical manner and form language, and then we will be providing details on how to submit those. Some commenters said that the child care program should not have to submit the requests for medical exemptions, but we're not making changes there either because New York State requires schools and child care programs to maintain those immunization records. They're responsible for knowing the immunization and exemption status for their children, and we think this is really the most practical and enforceable approach. There were comments that the program should not have to provide documents to us immediately, and we did make a change there. We know that some programs that are multi-site keep their records in an administrative office electronically, so we have clarified that you can provide us with electronic records on site, and so there's no need to go to an administrative office, and we think that that will address that concern. Next, there was a comment about the prohibition on single-use polystyrene, which was that the Department of Sanitation allows waivers. We agreed that is correct, and so we have amended to account for those waivers. There were a few comments asking us to add specificity around the new enforcement amendments, to add some details on which public health hazards could be the basis of a closure, and to set the details for the administrative hearings for reopening to address the due process procedures. And we have added those. They really mirror Article 47. We thought those were good comments, and that goes to our overall approach to try to align Article 43 and 47 a little bit more. On the class size, we had initially proposed to you to expand the group size for 3-year-olds, which is currently 15. We considered increasing it to 17. We're holding that change and not bringing it to the board at this time. We need, given all of the changes across the child care system, we need a little more time to evaluate this. And note that child care providers can come to us on a case-by-case basis asking for that modification, so we don't see any burden in taking a little more time to evaluate that. And then finally, we received comments on the proposed changes regarding medical rooms. First, that the requirements shouldn't apply when the school employs a non-city provider, and we agreed, and so we amended to apply the requirements only where the city is applying clinical staff. And then some commenters said that the standards were too burdensome and could require significant expense. And the code does allow for modifications, and so if there's a particular program that finds it to be a burden, we can work with them on a modification request and address on a case-by-case basis. With that, we can take questions.
All right, so thank you very much. We will open for questions. Ms. Redley.
Hi, thank you so much for that overview. That was actually a very quick overview on a lot of different topics, so thank you. And something just caught my eye relative to the medical room standards for non-city employed nurses. I think that's something to just talk about a little bit. I mean, what is the criteria, what is the purpose of the standards of the medical room? Is it meeting certain health standards for care of children? And then to say it's okay as long as the city is not employing the nurse. I just want to understand the principle that's being applied there. Because I'll say, on the other hand, I was, kind of supportive of organizations that had facilities limitations from, because of the age of the building and, wanted to make sure there were waivers and that type of thing. So I don't know, I'm just interested in your principle that you're applying.
So a colleague from Family and Child Health will come to address those questions.
Good morning. Introduce yourselves, please.
Sure. Good morning. My name is Daniel Stevens. I'm the Deputy Commissioner for the Division of Family Child Health.
And my name is Gail Adman. I'm the Nursing Director for the Office of School Health. So just in response to the question, the New York City Administrative Code requires the city to provide a school nurse to certain schools, but it also requires that these schools have medical rooms and allow the department to set standards for those medical rooms for schools requesting the clinical services. This proposal sets out those standards. The proposed medical room standards have already been incorporated in the Chancellor's regs, which govern DOE schools, but placing them in the health code would ensure that charter and non-public schools also know what an appropriate medical room entails if they wish to receive the clinical services from the Office of School Health, including a nurse. We need to ensure that our school health nurses and other health support staff have adequate facilities in which to care for students.
I totally support that. That makes a lot of sense. I'm just interested in the fact that we're saying the requirement should not apply where school employs non-city nurses. So just the consistency or the principle that we're recommending. Is it okay? So then we're saying it's okay that the medical rooms are not up to what the city's standards would be if the nurse is not employed by the city. I mean, it's sort of like, are the guidelines for the nurse and the appropriate care, or the guidelines for the care of children and the safety related to that?
I see. So I think I understand the distinction you're calling out and saying, kind of inconsistency. As with other kind of standards, when we think about kind of standards of care, we want to be able, the spirit of this is to be able to set the standard across. And in schools where the city isn't providing a nurse, while we want to make clear what the standards should be, we just, in this, we don't want to go to the point where we are burdening them with not being able to meet the standard, but we want to be able to set the standard of what really should be a safe environment for clinical services to be delivered.
Do we have an idea about what number or percentage of school facilities have non-city nurses?
We have about approximately 64 schools where those schools are not up to standard, but we've been working with those schools to make sure that the nurses and the clinical staff have the appropriate room to provide care to students.
Thank you.
That's for me.
I just want to chime in and support Ms. Redliner's comment. It feels like the requirement was created to ensure that city-employed nurses have what they need to do their job, but maybe not so much with the intent of ensuring that the medical room and the provision of services meets the needs of the children in every school in the city. And I share the same concern that what you are allowing is these 60-some-odd schools that do not have medical rooms that are up to snuff based upon what you would expect if your nurse was there to continue despite having set a standard you're not enforcing it. And I guess my question is why?
Jump in here. There isn't.
Oh, okay, thank you. So one of the reasons we're doing this, there's a local law that commits us to providing a nurse when there's a request for by a private school for a city nurse. But that law says that we're to impose standards for that nurse provision. So that's one of the reasons we're doing this, because that local law allows us to set the standards for schools where we set the nurse. And that's really the main purpose, why we're doing it. Correct. In terms of the schools where there isn't a city nurse, which I believe is a handful of private schools, some of the examples. No, I think that was a different answer, right?
So just to clarify, those 64 schools currently do have a school health nurse in the building? Yeah.
Yeah, the question, I think, that's why I think there was some confusion in the question. The question was actually what number of schools don't have a city nurse? And I think there are a handful of private schools that contract with their own nursing systems. Those nurses also, I would assume, they have their own standards of care that they're going to have to live by, and there'll be something in there. But we're not actually in a position also where we're going to enforce there. But there are professionals going in who will, be setting presumably their own standard of care.
So if I could just respond, if I understand correctly, what you're saying is that your authority is limited to schools where you are providing a nurse at the request of the school, and you want to ensure that standards are met when you're providing a nurse. but you don't have the authority, at least it's not written into our code now, to mandate certain standards for any nursing room in any school in the city.
Our authority is clear for when we're providing the nurse, and in fact, we're charged with coming up with standards in that case. I think pragmatically, it would be difficult to go out and to enforce in schools where we're not present.
And just to point out, I know that at our institution, there's a network of school-based health centers that are funded through a state grant that I believe all of the health professionals are employed by Mount Sinai, not by the school. It's quite an advanced, high standard health practice that's full thickness. And I presume doesn't fall under this, nor would there be concerns about the medical room. But there's a bunch of those around the city that different institutions run.
Right, all of those need to conform to Article 28 requirements, and so this applies only to where services are being provided by a nurse not within a primary care setting in Article 28 setting.
So, thank you so much. It's a very interesting conversation about this. But the non-city nurse, the schools that have non-city nurses would understand what the city standards are and presumably aim to reach them as well. But now I'm interested in the 64 that don't meet the current facility standards. And I was, thinking about the flexibility that you offer those schools to have time to meet them, or you're working with them to get closer. So, that there's no deadline for them to meet all of the standards and risk losing a nurse. That, my goal is, like, we hope that no schools will lose a nurse in their environment because the current facilities are not up to the standards.
Right, so the goal is not to remove nurses. The goal is to work with the schools to just make sure that the nurses are able to practice in a safe environment.
Perfect, thank you.
Dr. Richardson, did you want to?
No, I thought that it sounded like it was a question of the legal authority being tied to the request for a nurse in terms of the legal authority of the board to actually set standards for the facility, so I think Tom addressed it.
Any other questions? Okay, so then let's go through, sorry, I need to get my right papers here. Let's go then through the motions separately. So the notice of adoption to amend Article 43, school-based programs for children ages 3 to 5 of New York City Health Code. Notice was published in the record, so all in favor of amending Article 43, can I get a thank you motion? Second. All in favor?
Aye.
Any opposed? Any abstentions? Okay, so then that moves forward. Then notice of adoption to amend Article 47. Can I get a motion?
Second.
All in favor?
Aye.
Any opposed? Any abstentions? Notice of adoption to amend Article 48 in summer camps. Can I get a motion?
We didn't present that one yet.
Oh, sorry. Let me skip down to 49, thank you. Notice of adopting to amend Article 49.
So moved.
Second? Second. All in favor?
Aye.
Any opposed? Any abstentions? Okay, that one moves forward as well. And now we go to presenting Article 48. Thank you very much.
Good morning. So similar to what Corinne mentioned, just a brief overview of which modalities and programs, thanks Corinne, 48 governs. So those are summer programs, particularly day camps, overnight camps, and traveling camps operating between June 15th and September 15th of any given year. What our proposal is intending to do is to align with New York State requirements, detail immunization requirements, specifically the elimination of the religious exemption, prohibit peeling paint, and required earlier submission of the permit application. No one testified, but however, we received 5 written comments. There were a request for additional guidance, of which we're going to provide in writing, particularly at FAQ, and also during inspections when we're on site with the providers. Some of the commenters had questions about the restriction on occupying above the 3rd floor. Their concern was primarily steeped in the fact that some of them operate above the 3rd floor currently. So we amended to clarify that the occupancy is allowed where it's approved by the department as well as FDNY and Department of Buildings. Also, we clarify that this applies only to programs serving children younger than the age of 6. There were also questions around emergency medical services. Particularly, it was unclear what arrangement is actually needed to meet that requirement. So what we did was amend it to clarify that the written safety plan must include the location of the closest emergency medical service. Questions?
All right, questions? Dr. Richardson.
Yeah, thank you. So I just have a question about what is meant by emergency medical services within the context of this language. I usually think of EMS as an ambulance, which means dialing 911, but you mean the closest facility that provides emergency care?
Correct.
And would that include urgent cares or only a hospital-based emergency department? What would be considered an adequate emergency facility?
So only if the urgent care can supply and provide emergency services, we will accept that in their written safety plan. Primarily, we do intend for them to include hospitals.
Okay, so you will decide whether or not a specific urgent care has the capacity to handle emergencies?
Correct.
That should be interesting. And my comment is simply because many of them purport to, but when you look at the services actually provided, I, of course, am an emergency physician, and every day I get referrals from urgent care centers of patients who went there and are now sent to the emergency department because they're not able to provide the level of care the patients need. So I'm really not sure how the department would sort that out, given the rather
Complex
confusing
nature,
language that many of these providers use in terms of their, what they purport to the public to be able to do and then what they're actually able to do. So you might want to make sure that there is actually hospital-based emergency department specified in each one of these safety plans.
We'll take note of that. Thank you.
So, I have a
Ms.
question.
Radlin, yes.
Just for me to understand, this is meant as a place that you would take a child in an emergency, or it's meant that the EMS or some medical response would come to the school?
Both, because we want to ensure that they're not traveling too far to seek emergency care. So if they do need to take the child directly there, we want to make sure that it's within an approved time frame. But also if EMS is responding, it's the travel time between picking up the child and taking them to the nearest location.
Thank you.
Any other questions? Okay, thank you.
Thank you.
So, on the issue of amending Article 48, can I get a motion, please?
Second.
All in favor?
Aye.
Any opposed? Any abstentions? So moved. All right, so then, thank you very much. We will move on then to the next part of the agenda, which is a discussion on revisions to certificates of birth, death, spontaneous termination of pregnancy, and induced termination of pregnancy forms.
Okay, good morning, everybody. My name is Gretchen Van Ly. I'm the Assistant Commissioner for the Bureau of Vital Statistics, here today to talk to you about forms. And we have proposed changes to 7 of our forms, as Dr. Barbeau. What I'll do is I'll list the form, the changes that we're doing, and I'll show you what it would look like before and after. So the first form we're planning to make a change to, or we'd like to make a change to, is our certificate of birth form. For this form, we would like to, and I should also preface by saying that a lot of these changes are just housekeeping types of changes. Some of them are for gender inclusive language on the forms, and one is to add X as a decedent option on the death certificate, and I'll explain all of these as we go along. So on the birth certificate form, we first would like to add the suffix to the name of the child, and so that will be so that it's consistent with the US standard birth certificate. Similarly, we want to do the same with the parent's name. And then because we've made the X designation for a registrant on birth certificates, we now want to make sure that it's a possibility for parents to have their gender marker listed as X on their child's birth certificate. So this is what our current form looks like. See the fields that we proposed changes to are highlighted. And then this is what we're proposing. So you can just see that we're adding the suffix, the additional gender marker on these forms, on this form. Okay, and, oh, sure. Sure, yes, absolutely.
Yeah, we could do that.
We do that as we go, because there's so many forms.
Sure,
Yeah,
of course.
Thank you. So are there a set of approved suffixes that are allowed?
That's a good question. So, I'm
I
not
assume
sure.
you mean things like junior or the
Yes.
third and so on?
Yes, and so, so I'd have to look to see if we do have a list of approved suffixes. I'm not sure. I think they would be the standard, and the US standard has provision for this, so we're just becoming consistent with the
I'm
US.
surprised this is not currently allowed.
Right, exactly. In fact, some of these housekeeping provisions are things that we've, as in going through our forms and with a fine tooth comb, we've realized that should have been updated in the past. So,
Yes. Dr. Glitzman.
Thank you. This Board of Health loves forms. In a previous discussion, as you probably recall, we discussed persons being able to amend their birth certificate to add X. So is there any linking that with this change, interest, proclivity to match a parent who wishes to change their gender on the child's birth certificate with their own birth certificate if they were born in New York City?
we think this is already covered under the existing health code provisions and forms that we have in place. The correction application has a place for changing other types of.
So a person would have to request this, the change on their birth certificate separately. There would be no way to automatically make sure that this change matched their own birth certificate.
So, right, so this would be specifically the parent, so there are two ways it could happen. So at the time of birth, the parent would identify to the hospital and would put it on the mother-parent worksheet. And then the hospital would then enter it into our system, and then we would register it as it was reported. And then if there's somebody on the legacy certificate who decides to go back in time and say, I want to make that change to what my gender marker was in box 6A or box 8A, we think that's covered under the existing rules.
It would be a separate.
Okay, so
And
just
those are two
to
separate types of-
make sure I understand, the individual would have to take two separate actions. They're not linked at all. There's no way to link them.
That's correct, because because people come from all over to give birth, so we don't necessarily have their birth certificate. Yeah, and so, and there's not necessarily the same, they're not necessarily using the same name as a parent as they were on their original birth certificate.
Of course, yes. Okay, thank you.
That's form.
Thank you. It's always interesting to think about these forms. The details matter. I want to propose a potential scenario and ask you how this would be handled.
Okay.
So imagine a middle-aged parent who comes and submits a request to change their gender to X on the form of their child who was born here in New York City. So you have the birth certificate of the child here. On the original birth certificate, they were male, and they want to change it to X. Does that require the consent of the individual child
Oh.
to make the change, or just the parent who's requesting?
That's a great question. Let's just to play it out. So the way it works for making a change on like a minor's birth certificate now is that both parents, both people listed on that certificate, need to sign off on that correction.
So proposing a circumstance in which the child is now adult. So the
Ah.
child, let's say the child is now 20,
Mhm.
and the 45-year-old father comes in and wants to make this change.
Right.
Is there a requirement that the child agrees to that change?
Once they're 18. Yeah,
So
once they're
how
18,
would
they
that-
have to.
They would have to both then sign the form.
I think only the child can change at that point.
Yeah, I think we will double check, but once they're 18, they have
That
ownership
raises
of
the-
their form, yeah.
That raises the issue of what if the child presents at age 20 and wants to change their parents' gender, but their parent doesn't agree?
So this, thank you for that question, because this is a good segue. This is sort of like foreshadowing for what we were thinking of, we were thinking of this could happen with death certificates, not as much birth certificates, because birth certificates, we have a provision for that, but on death certificates, if a loved one subsequent to the time of death, maybe 5 years later, wants to change the gender marker of their parent on their certificate, what we'll do is presumably that child could be the informant on the death certificate, and that's sort of the controller of the decedent's affairs, and so we would write a letter to that informant and say, this is what somebody has proposed to do, is this okay? And the informant would then sort of be the gatekeeper for that,
But I think that isn't there a requirement of documentation in support of a correction? So
Yes.
I think that's how you would deal it. So like if I wanted to go and change my father's gender on my certificate, if I produce some sort of affidavit from him or something like that, I think that's how we would handle it.
Yeah, posthumously.
Okay, we have 7 more forms to
Okay.
file.
Okay. So for confidential medical report of birth is really technically a part of the VR6S, but it's treated slightly differently, so just handling it differently on this slide. What we'd like to do for this form is add Spanish and Latino to the ancestry label to make it consistent with the US standard. We'd like to change the question for the fetal genetic testing to make it gender neutral language. And we'd like to remove Family Health Plus from the primary payer. This is because Family Health Plus no longer exists. This is an example of housekeeping. So this is what the current form looks like. You see the ancestry in the top left, then on the right-hand side there, we have if the woman was 35 or over, was fetal genetic testing offered, and then in box 17, we have the financial coverage question. And this would read to include Spanish and Latino in box 11. It would say mother/parent on the right, and then the primary payer would just be listed simply as Medicaid. We'd remove the other text. Okay, we also have a different legal form for the adoption birth certificate. We want to make the same changes that we're making to the regular birth certificate. We'd like to add the suffix to the name of the child and to the parent, and we also want to add X as an option for parental sex. This is what it looks like before, and then as proposed. And then to the death certificate. So for the death certificate, we're asking to do the similar types of things that we're having for the birth certificate, so adding the suffix to the decedent's name, adding X as an option for decedent sex. We also would like to change the label name of the certifier. Now this is a housekeeping for a health code change that was made in 2009. What we'd like to do here is just list nurse practitioners and registered physician assistant options to the certifier's signature box. As I mentioned, per this health code amendment that was made in 2009. We'd also like to add gender neutral language to the partner name, so just removing the phrase if wife. And then we want to add gender neutral language to the parent name and add Spanish and Latino to the ancestry label. So this is how the current form reads. And this is how the proposed form. Sure. Backwards? And that's the first part. You'll see that in this this particular, if you're looking at box 4, which is the sex box where we're proposing to add X as a response category for the gender marker, it's not actually explicitly listed there with little lines like it is in some other forms, but it's a response category.
I'm sorry, I'm trying to read I'm trying to read the ancestry
Yes.
boxes that are highlighted. So we're adding the terms Spanish and Latino.
Right.
And what does the second,
This is,
what's the bottom box?
Not Spanish.
yeah, it's just not.
Yes or no?
So it's not any of those things, but they're not the same list of things?
Oh, it's actually saying not, and then the parenthetical phrase is saying what it could be, what the answers could potentially be, for example. So it's either Spanish, Hispanic, Latino, including Mexican, Puerto Rican, Cuban, Dominican, etc. And then the box says not Spanish, Hispanic, Latino, and then in parentheses it says Italian, African American, Haitian, Pakistani, Ukrainian, Nigerian, Taiwanese, etc.
So if you were a white Spaniard from Spain, what box do you check?
Well, I think we leave it to the person to, as they self-identify.
But they have to check off that they're not Spanish to be able to then write in specifying Spanish?
They could specify either box, so there's a specify line for either box. So, they could do it here, or they could do it here.
So you said what was your name?
If I'm from Spain and I identify as Spanish, Hispanic, Latino, I could write it from Spain here, but if I do not, then I could write it here.
So I check off that I'm not Spanish, Hispanic, Latino, and then write that I'm Spanish? That would be okay?
We would take it.
Okay.
It's
I mean, I really support the addition of Latino,
Yeah.
because as you know, many
Yeah.
people from those ethnic groups don't really embrace the word Hispanic.
Right.
I'm not sure
Right.
where the addition of Spanish
Right.
came from. I think it adds confusion because
It's
Spain
the-
is a country rather than an ethnicity.
Yeah, actually, this was a point I was gonna make afterwards. I think that, I know that the program is looking to follow the US standards, but sometimes US standards lag behind what the cultural reality is, and Spanish is a language, it's not an ancestry. So I think that my proposal would be to strike Spanish and just keep it as Hispanic Latino. And then, certainly we could either add Spanish within the parentheses, but I think in this situation, it wouldn't be something that we would want to incorporate because of the US standards lagging behind cultural relevancy.
And just along those lines, do you have any sense of how those who analyze the US Census at the federal level, what they do with that information? Does it add anything useful or important?
Well, that's a great question. So there are reports that use the race and ancestry ethnicity questions together to do analysis, but whether or not whether it adds something, an additional nuance of
Right, specifically whether adding the word Spanish
yeah.
gives us any important information that we wouldn't otherwise have.
My understanding from work talking to colleagues at the federal level and then in New York City is that there's a general feeling that the response categories that we have broadly are not adequate for answering these questions, and so I think my understanding is that there was an intention to pick as many words that would be as inclusive as possible for however people would identify. But I haven't really had a deep conversation about the merits of this particular, and we could look into that more.
Rosa, did you want to make a?
Just keep holding it, yeah. I think that I'm a little bit concerned. I agree with you, Commissioner, that Spanish refers to a language, not to ethnicity, race, or and so on. And then the other concern is more and more we're using Latinx throughout the country and in this region. So, I mean, this presents another option for people who may say, Latinx. But if we're going to change this, I would suggest is Hispanic and Latino, as opposed to throwing in the word Spanish.
Right, I think that this is a balance between having harmonization between terms that are used elsewhere, like Hispanic and Latino, and not incorporating terms that are either no longer currently used or not yet fully adopted and accepted. So, how's that for threading the needle? Yes, Dr. Foreman.
So just to thread one more, I'm not sure I like your suggestion, and so it would read, the first box in 23 would read Hispanic/Latino, and then maybe include the word Spanish in the list in parentheses following. And then the next one would say not Hispanic, Latino, and I wondered if then you would not include Spanish there, or you would include Spanish in the list.
My recommendation would be not to include it anywhere.
I support that.
It does say et cetera, so there are other possibilities.
That sounds great.
Yes, that's Karen.
I study medicine in Barcelona. They don't consider Hispanic. They consider themselves Catalan. Then the etc. will be there. Another question. About more than 20 years ago, I had a patient who lived as a female from age 13, and he was my patient. He has male genitals, but lived as a female with Social Security, ID, everything as a female. If that happened today, is how that person die, consider herself or himself, or the natural biological description of the disease.
So, for that would be female. If the gender identity that your patient was expressing was female, unless they had explicitly said that they did not want to have it reflected as such on their death certificate, and which they could because of whatever reason, then there would be female. We would want the medical provider to make every effort to correctly assign the gender with the wishes of the decedent.
Okay, continue, please.
Okay. And then this is the medical examiner death certificate. You may recall that we have a different form for the medical examiner certificate, but we do want to make the same changes to this particular form. So this is how the form looks currently, and this is how it would look after, and we would make the same changes to the ancestry boxes, really to all of the forms presented. And then we're making changes, or proposing changes to 2 additional forms. These are the spontaneous and then induced termination of pregnancy forms. So first, the spontaneous termination of pregnancy form. First, we'd like to add undetermined as an option for fetus sex to match the birth certificate. We'd like to add X as an option for parental sex to provide the option of a non-binary gender marker. We'd like to add Spanish and Latino. Actually, we'll just add Latino to the ancestry label now. We would remove never lived in the US to match the labeling from the birth certificate. And we would reorder the pregnancy factors to be consistent with what's on the birth certificate. So this is how it currently looks. And this is how the proposed form would look.
Sorry, go back.
this was, I'm sorry.
So if this was someone who was born outside of the US, who had never lived in the US, they would put 0?
Right, so this is to be consistent, and that would be the probably how they would complete it, or maybe they would write in point, depending. We would have to clean the data.
Yeah. So should it be, if born, they check it? I'm not sure how to fill this out. I mean,
Sure,
just as a form.
sure.
Looks a little cryptic.
Okay, so it's, so if you're born outside of the US, how long have you lived in the US? And this is the provider is asking this to the patient, who's experiencing the spontaneous termination of pregnancy. And so maybe it's just really to be in years, but if they would feel that they would like to say half a year, it could be 0.5.
So if they're born outside of the US, you check the box, and then on the lines below is where the amount of time
Yes,
they were in
yes.
the country.
Yes, sorry, yeah.
Yes, Dr. Moore.
Can I propose a formatting change to box 27?
Sure.
I think the way I would do it is the part that's highlighted would just continue. It would say, if born outside of the United States, how long lived in the US, years, or continuing right there, or if less than a year, months. And then you have, I presume, 2 lines under mother parent and father parent in case there are 2 mothers or 2 fathers. Is that correct? Or were you intending for it to be years on the top line and months on the bottom? If you intended it to be years on the top and years on the bottom, I would scratch that and just put parent 1 and parent 2 and include the or if less than a year, months with the initial description at the top.
Okay, so,
What's the intent of the 2 lines on each side?
That's like, Gretchen, you think about that.
yeah.
I think the
And then I'll
problem is
take
if
your
you
question.
write a number, then it doesn't make sense.
So, I have to, now that I'm looking closely with you at this form, I'm not remembering exactly how exactly we were expecting that to be answered. I was expecting it to be, it's kind of reading both ways. It's very confusing. But we can modify it as you suggest. So what I'm understanding.
I think the point is, though, to, in the instructions, make clear how many years, and to indicate if less than 1 year, to indicate it in months, and then to have just 1 line for parent.
Yeah.
And I guess the question is whether we want to have mother, parent / father, and just father, and have that be replicated so that it's sort of multi-purpose.
Mother / parent and just father, parent, and just one? Or-
No, mother / father / parent, and have that be the same line label for both. So that way you don't need 2 places to indicate mother and father.
Well, you do, because there's 2 of them. Why do you want to have both?
But it could be 2 others.
But you have
Robin.
4
I
right
have a
now.
larger
You have
question.
4.
I have a larger question, which is why are we asking this question?
Length of time in the US, it's something we can look at we look at it for health outcomes. We're interested in health outcomes. So if exposure, for example, we know that the longer people live in the United States, the more likely they are to experience obesity. So, so there are certain things that we look at from a health outcome perspective that are associated with duration in the United States.
Yeah, I guess I would just argue that I don't really see the relevance of a question, even in looking at health outcomes.
Okay.
But, the researchers in the room could argue with me, but but I just don't see it from a practical standpoint.
Yeah, because we do ask for the place of the mother's birth. So one example is we recently did a paper on preterm birth, and we looked at the mother's place of birth, and we could, from a data perspective, we could look at how long the woman had lived in New York City and before she gave birth, and we were interested in the exposure to sort of the anti-immigrant rhetoric of the federal administration, and we were able to tease that out and understand where people were at certain points in time. It was a understanding the population better. Yeah.
Yeah, I just wanted to support, since you kind of invited the researchers in the room to disagree with you. I mean, I think it's really important to capture detailed data to achieve health equity. I think sometimes in an effort to promote fairness, we try to obscure the details and that actually works against our ability to monitor disparities and achieve health equity. So we know that immigration status and length of time in the U.S. is an important factor in many health outcomes. So having data on that allows us to better understand what is happening. We had lots of questions about this one. I don't know if it would be possible to approve the others and maybe have you think about this more and come back, or is it important to do it all at once?
We can do whatever. We can move on and then come back to this.
Because then I think that would be my suggestion. I know, but I don't think we should do it on the fly and then 2 years we're looking at it and say, why did we do that?
Yeah.
Yeah. So that would be my suggestion. I don't know if we need a motion or if this is just informational or exactly what's. I think we have to approve these.
No.
Or are we just
Yeah.
discussing
You need
it?
to approve
Be
them.
careful what we approve so we can say that changed, not approved.
Got it.
Could we just see the current box 27, just
Oh, sure.
see?
Yeah. Go back to the chief.
So never lived in the US, that's being removed, so the rest of it is just the same. Exactly.
Right.
Yeah. So this is actually keeping it, that language which is confusing to us at this point is the current language as well. So interesting continuing discussion. Okay.
I'm sorry, I realize what's happening here is this just provides places to write in years or in months. I think that's what Dr.
Right,
Foreman
yes.
originally said, yeah. And then for the father and the mother, because we do allow only 2 parents on our records.
Yes, that's closer. And then Dr. Richardson.
Okay, now that we're delving into this, I realize I have some questions on what is the best way to characterize the parents, thinking ahead toward how you might be analyzing this information. It's unclear if you're seeking to know in box 1 the gender, or just either way, if it's mother, father, or parent in both boxes, it might be hard to tease out the gender of the parent, and if that's an important risk factor for spontaneous abortion, risk factors related to a female parent, risk factors related to a male parent.
Right.
I'm just wondering what's the best way to capture this?
Well, that's why we've kept we're proposing mother/parent and father/parent to anchor it in the people completing the forms in those roles, so that we can analyze the data better.
Right, but as one of my colleagues pointed out previously, if there are 2 female parents or 2 male parents, that option would make it difficult to capture that or even classify it that the parents were of the same gender.
I see. So the birth parent is supposed to, yeah, there is a gender box, but there's also the intention is for the birth parent to always take the first place on the forms. That's another anchor from a data collection perspective. But yes, we do have the boxes as well.
That's one.
Could you flip forward to the proposed one? Yeah.
One what?
Next one. Yes. So what is important to the department is information on the birth parent and the other parent, regardless of whether they view their gender as male, female, or X or whatever. So maybe that's what it should say. And I agree we should probably bring this form back so we can see the final version before approving it. But maybe it should say column A is birth parent, and column B is other parent. Doesn't really matter. The rest of it doesn't matter. And for the birth parent, you ask for years and months, and for the other parent, you ask for years and months. Does that make sense? I think it's just clear, because it doesn't really, the rest of it doesn't matter.
So we would just want to make it consistent throughout all of the forms then. So would we do birth parent on all of the forms?
I get at what's the purpose of gathering the information.
There's the,
So you
for
want to
the,
make sure you meet your needs.
yeah, so the birth parent, on the birth certificate, we collect, there's the confidential medical report is about that person who carried the fetus. And so that's, there's a lot about prenatal care that's completed. And we said, we had proposed mother/parent because to keep the majority of people who are completing this for the majority of cases clear on what order to put those parents in on the certificate. And so that principle generally, we generally then try to make within our certificates consistency across the certificates, so birth, and then these two, because these are the stop and the ITOP, or the spontaneous and the induced terminations are really outcomes of pregnancy.
So then maybe it should be mother-parent, and because it could be two mothers.
Right, so.
But you want to distinguish the mother that carried the child from the other mother, or carried the fetus, I should say.
Right.
So
I see
that's
what
why,
you're saying.
again, it seems like what you want to be able to do is associate time in the US with the actual mother
Mm-hmm.
who carried the fetus that was terminated,
Mhm.
right? So you have to know which of these columns is that person. So if you did mother, father, parent, and both, you don't know. So you want, that's why you did it this way, mother, and
Yeah.
assuming
Right.
the other is the father, but it could be a mother. So
Right.
it just has to be very clear which of these is gathering information on the actual person who carried the fetus. And that's the piece that's hard.
Maybe we can just say birth parent.
Which is why I suggest
You think birth.
and other parents, which is
I-
why I did that.
Yeah, I mean, I think though we're losing sort of clarity in an effort to be politically correct. I think most often, as you point out, in this situation, there will be someone who identifies themselves as mother, who is actually releasing this fetus from their body. I don't think we have to remove all familiar terms in an effort to be gender neutral. We just need to have the opportunity for everybody to represent themselves in the way they want. So maybe the compromise is mother/birth parent and father/other parent or non-birth parent in the other one, but I think I don't really feel like we should remove the terms mother and father from all of these forms in an effort to be politically correct. I think it will just create a lot of confusion.
Also, fathers, non-fetus carrying fathers are also birth parents. The language doesn't work.
Yes, no, you're right. So I'm actually fine with the mother/parent, father/parent. I didn't support the change you suggested, Joel, to make everything mother, father. I think that would also be confusing. I would sort of leave this part as is. But in terms of the other forms, I wondered if the department or perhaps even on a national level was issuing any guidance to the people who usually complete these forms who make changes to confidential medical record, which I'm often in the position of having to fill out on death certificates and birth certificates. And because now some of this is no longer intuitive and familiar.
Yes.
So.
There is a lot of guidance. We work very closely with the National Center for Health Statistics, which has a lot of guidance. We have, we also have e-learnings, we have written guidance, we have quality improvement groups that we're constantly looking at the data to improve. So that's where a lot of these standards come from.
And the sort of lay informant for the death certificates are reporting to funeral directors who
Right.
also need to understand.
Right,
this.
so the way a death certificate works, we start with the decedent. The medical certifier is the one who's completing the first part. Then the funeral director plays a role for the personal particulars. But the medical person is the one completing the top of the death certificate. here, so including box 4, which is the sex field. And so then the funeral director comes in, and then eventually we receive it to register and to issue the disposition permit.
So just to capture where we are as we move forward,
Yes.
On this particular form related, if you can go to the actual slide, related to spontaneous termination documentation, where we are is that we will clarify indicating years versus month of living in the US, and that we will clarify, we will retain the current convention, but just add birth in front of the first mother/parent, only for this form. Is that
That's not what I heard.
I think we decided
No birth.
no birth, just leave it as is?
Mother/ and father/.
So we'll leave it as is. Okay, so the only clarification then on this particular form is years versus, if less than 1 year, clarifying, indicating months.
Right, and the box 25, which will make consistent with what was proposed previously.
Yes.
by the
Yes, that's good.
Correct.
Okay,
That's
all right.
box 27.
Okay, and, let's continue.
So, finally, the induced termination of pregnancy form will add just Latino to the ancestry label, and we'll also add nurse practitioner, registered physician assistant, and licensed midwife options to be attended. This is to be consistent with the health code, and this will be in 2 places on the form. So this is what it currently looks like, and as proposed, it would be, oops, I'm sorry. Strike the Spanish, and then those would be the provider boxes to be.
Okay, thank you. So, do you want to ask a question?
Well, there was just one section that we didn't talk about, the pregnancy factors, I don't know if that matters.
Oh, sure.
You know, the change in the pregnancy factors.
It's just reordering the list to be consistent with what's on the birth certificate. For some reason, they were different, and
Just
so that's just like a
reordering,
house
got it.
cleaning thing. Yeah.
Okay, thank you.
Okay, so what I propose is the following, is that we approve the changes that are being recommended, that we have given sufficient clarity to the program to indicate years and months, and that we don't then need to bring any forms back for the board to review. Okay, so the motion then, we have to do it?
Well, just take a vote on that.
We'll take a vote.
With the elimination of Spanish.
Right. So the motion is to approve the forms with the amendments of removing Spanish from the ancestry box in all of the forms and clarifying years and months on the termination form. Can I get a motion?
Second.
All in favor? Opposed? So moved. Excellent. I think this is an interesting sort of view into the reality and the importance of the vital registration function that we serve, and trying to, as closely as possibly, capture the reality of everyday New Yorkers, continue to give them the opportunity to live their fullest lives and have that be codified both in birth and in death. So thank you all very much. Yeah, no, it is totally profound, yeah. It definitely matters. So with that, and I want to thank you all. I want to wish everyone a happy, healthy, and safe holiday season, and we will reconvene in 2020. Thank you. You're adjourned.
Thank you. For that, it was easy.